presentation by Dr. Vivek Veldumani. He is present. Okay. He will be presenting on intraocular pressure changes after intravitreal dexamethasone, that is Ozurdex sustained release implant. Okay, doctor.
Morning. My paper is about the intravitreal Ozurdex and the intraocular pressure changes after implantation. We have no financial disclosure with regards to the study. Intravitreal corticosteroids are being increasingly used for a number of posterior segment disorders, and the most common side effect observed is increase in the intraocular pressure. Ozurdex, coming to Ozurdex, it releases dexamethasone for a period of 6 months, and it is commonly used dosage is about 0.7 mg and reaches the peak concentration about by 2 months. And the pharmacokinetics of Ozurdex is found to be similar in both vitrectomized as well as non-vitrectomized eyes. In this study, we have evaluated the incidence and risk factors for rise in intraocular pressure after implantation of intravitreal Ozurdex. This is a retrospective study conducted between July 2021 and December 2022. All the patients had at least 3 months of follow-up, and details such as demographic features, indications for Ozurdex, prior history of any glaucoma, and the baseline IOP at each follow-up, and the lens status and the history of vitrectomy were collected. Patients with having eyes with macular edema due to diabetic retinopathy, retinal vein occlusion, and non-infectious uveitis were included, and patients who had at least 3 months of follow-up were included in this study. Patients having vision worse than 20 by 200 and prior history of any usage of intravitreal corticosteroids and prior history of existing glaucoma and poorly controlled diabetes and systemic hypertension, and patients who had less than 3 months of follow-up were excluded from our study. So rise in IOP was defined as single measurement of more than 25 mm of mercury or an increase of more than 10 mm of mercury from the baseline. The baseline IOP and the IOP after 1 week, 1 month and 3 months after injection were analyzed. 30 eyes of 30 patients were included in our study, of which 28 eyes received a single dose of intravitreal Ozurdex and 2 eyes received 2 doses of intravitreal Ozurdex. Among those 28 eyes, 2 eyes had a IOP rise, and among those 2 eyes which received 2 doses had a single eye had a IOP rise. So on the total, IOP elevation was seen in about 3 eyes, which contributes about 10% of the cases, and they were treated with topical anti-glaucoma medications. The mean age of the study population was found to be about 54 plus or minus 15 years, of which 16 of them were male and 14 of them were female. The most common indication for Ozurdex in this study was found to be about non-proliferative diabetic retinopathy and proliferative diabetic retinopathy 2 cases, and retinal vein occlusion 4, and non-infectious uveitis 5. In our study group, 17 of the patients were having phakic and 9 were pseudo-phakic, and 2 of the patients developed cataract after implant with a mean duration of about 3 months, and 2 patients underwent vitrectomy after a period of 3 months. So for matter of convenience, based on the type of indications of Ozurdex, we divided as that group A to be non-proliferative diabetic retinopathy, and assumed B as proliferative diabetic retinopathy, and C to be retinal vein occlusion, and D as non-infectious uveitis. So this coming to this table, we see a post-operative spike of the intraocular pressure during the first month of the IOP, which is shown to be maximum in the group A, and it is statistically significantly different from the baseline IOP, and the IOP actually returned to baseline after the 60 days or 3rd month. And we also tried to predict the IOP changes with the central foveal thickness during the first week itself, and the central foveal thickness was found to be reducing trend in all 4 groups, and there was a maximum reduction of the central foveal thickness in the group C, that is the retinal vein occlusion. So this is the fundus photograph of the patient having macular edema and the OCT with the central foveal thickness measured before and after. We can see the reduction in the central foveal thickness as well as resolving of the macular edema. This is a secondary visual outcome. All 4 groups showed a significant visual acuity improvement after the end of 3 months. This is the graph depicting that the majority of the cases were belonging to non-proliferative diabetic retinopathy, and the graph representing a peak in the post-operative first month, and the IOP actually returned to baseline after the 3rd month. Central foveal thickness also, all 4 groups showed a maximum reduction in the central foveal thickness. Visual outcome was comparatively good in all 4 groups. And we tried to find a relationship between the intraocular pressure measured at the first week and the central foveal thickness measured at the first week. And there was a very small negative correlation was found out, but it was not statistically significant in our study. So in order to conclude, the IOP rise was not related to age, sex or indication of injection in our study, and the eyes receiving more than one injection were at significantly higher risk for rise in IOP. The limitations of our study is we are having a short follow-up period because we have to follow up the patient for about 6 months, but in our hospital we are unable to the patient, we had lost follow-up, so the loss of follow-up is a limitation, and the small sample size could be a limitation of our study. So to conclude, intravitreal OCULAR is safe and associated with rise in IOP only in small percentage of eyes, and eyes receiving multiple injections are at higher risk of IOP rise and requires careful monitoring. These are my references. Thank you.
So before giving Ozurdex, how do you evaluate the patient for like whether he's a steroid responder or glaucoma related? Now before you give the Ozurdex, what do you evaluate? Any patient of whatever you have given indication will give Ozurdex, or you have any patient who say will not give Ozurdex because of glaucoma or something?
We have excluded the patients who are having already glaucoma.
You don't. Then what do you treat with them? Those patients, what do you treat? How do you treat?
So we control first the
No, with the patient with the macular edema, with glaucoma you don't give Ozurdex. How do you treat the macular edema?
We give on topical anti-glaucoma medications and we can start.
Ozurdex you will give. Piyush, you agree or Manoj?
Yeah.
No, you know, history of glaucoma is saying you will give anti-glaucoma and give Ozurdex.
No. There are any other options or other alternative medicines will you try?
Yeah.
Like anti-VEGFs or any other lasers, anti-VEGFs, or you give directly Ozurdex?
We can try a trial of anti-VEGFs and then can go for it.
Okay. And before that, what sir was saying, that you have to do this is steroid responder challenge test. You can keep on putting the drops for 1 week, 2 weeks, steroid drops, 2 hourly, 3 hourly, 4 hourly, and then see whether the patient is having steroid responder, and then you inject. Otherwise, it will be hazardous. Okay. Thank you.